We are live.
Okay. So, good evening, postgraduates, and welcome to this 71st episode of All India Postgraduate Teaching Program, an initiative from ARC AIOS. As you are aware, today is the 71st episode where we are having two talks. One is on the histopathology slides of cornea and ASOCT of cornea. And basically, these two talks basically have been kept for you so that it helps you in preparing your for OSCE presentation, OSCE exams as well. Histopathology of the slides as well as ASOCT, which is a virtual scan of the cornea, you should be able to correlate, and that's the reason why we have clubbed these two talks together. So today's first didactic lecture would be on histopathology slides of cornea, which would be presented by Dr. Dilip Kumar Mishra, who is a famous senior consultant pathologist at LV Prasad Eye Institute, Hyderabad. And the second didactic lecture would be on ASOCT of cornea, which would be presented by Dr. Rushad Shroff, who is a cornea specialist and a medical director of Shroff Eye Center, New Delhi. Of course, my special thanks also goes to Dr. Kaustubh Sane, who is a consultant at Netra Jyoti Kendra, Agra. Dr. Aditi Ghosh Dastidar, who is a consultant cornea and ocular surface at Synergy Eye Care, New Delhi. And our own Nagpurian, Dr. Rashmi Deshmukh, who is a senior consultant at LV Prasad Eye Institute, Hyderabad, for consenting to be discussed and sparing their valuable time. Now, without much ado, can I request Dr. Deepak Mishra, our member ARC from the center, to carry forward the proceedings. And meanwhile, I will request Dr. Dilip Mishra to share his screen.
Yeah.
Deepak, over to you.
Thank you, sir. Thank you. First talk, Dr. Dilip, sir, kindly share your slides.
Yeah, I am sharing my slides. Thanks, Dr. Prashant, for inviting me. So my slides are visible?
Yes, yes, yes.
It is now it is full screen mode. Are you able to see?
Yes, yes, great.
Yeah, thanks. So I am discussing now histopathology of cornea, normal versus disease. So when we discuss with histopathology, always first we discuss normal structure, then we discuss abnormal, means histopathology. So this is disclaimer for me. I have no any conflict of interest. So the basic thing, because this is PG level teaching, so first to know about the pathology. So during MBBS time, you have must learn about this definition. Pathology is a bridging discipline between the basic science and clinical practices, whereas ophthalmic pathology deals with the pathology of eye, adnexa, and orbit. So the aim of this presentation is to know about the basics of tissue processing. Then I'm going to discuss the normal corneal histology. And after that, I compare normal histology with infection and dystrophies of cornea. So these are the three main aims of this presentation. So corneal specimen, we are getting mostly corneal biopsy, keratoplasty specimen, and eviscerated eyes. And how we are preserving this tissue? It is always preserved in 10% buffered formalin, because this is cheaper and universal stabilizer, means fix the tissue. And usually half of the corneal button we are getting for the infective etiology, whereas for the dystrophies full corneal button we are getting. And for the electron microscopy, if you are suppose you are doing some research work, then you have to fix in 2.5% glutathione solution. So these are the specimen, 5 types of specimen mostly I am getting in my lab. These are penetrating keratoplasty, anterior lamellar keratoplasty, then deep anterior lamellar keratoplasty, that is called DELK, then DSEC lenticule and DMEC lenticules. So the common question is that how you have to preserve and transport the tissue after biopsy. So most of the people tell it is normal saline. I got phone call from other side of the other states. Sir, I want to send some samples for the analysis. So in which medium I have to transport? So the answer is you have to transport in not in glass bottle. this is the ideal container, plastic container, and it is 10% buffered formalin fixed. So the rule is 10%. 10% means formalin 10 ml, and that is if suppose the tissue size is 1 millimeter, then 10 ml of the formaldehyde solution should be in container. And suppose you have incised very tiny tissue like DMAC lenticule or DSEC lenticule. So for that, or corneal biopsy, for that you have to wrap in a filter paper and stain with trypan blue or eosine stain. So this container is showing eosine stain, very tiny tissue, less than 1 millimeter. Mostly it is Descemet's membrane or DSEC lenticule along with adhered filter paper. So you just see just for the how the cornea looks like in enucleated specimen. This is the enucleation specimen. You can see that this is the optic nerve, and this is the lens, and this is the cornea. So on enucleation specimen, the cornea is anterior. You know that anterior part of the eyeball is made by the cornea. So this is the cornea, and behind the cornea is this is the lens. So in our lab, this is the step I am following for the processing of the tissue from grossing to signing of the report. It takes around 48 hours to 72 hours and sometimes 5 days, depending on the type of the tissue. Generally, corneal button, we are giving our reports within 24 hours to 48 hours. So now come to the normal histology of the cornea. So as you know that cornea has 5 layers. This is the HNE stain on histopathology. Cornea has outer layer is epithelium, which is 3 to 5 cell layer. Then after that, Bowen's layer and stroma. And stroma makes 90% of the cornea. And this is the PAS stain, per iodic acid shift stain, which stain for the Descemet's membrane, whereas Bowen's layer is not positive for the PAS stain. PAS means per iodic acid shift stain, which stain for the carbohydrate or glycogen. So Descemet's membrane is a form of carbohydrate or glycogen. Due to this, they are PAS positive, whereas Bowen's layer is not PAS positive. And there is nodule-like structures. They are the endothelial cells. So this is the specimen of the exentrated specimen where anterior 1/6 of the eye is formed by the cornea. You can see that this is the cornea, and this one is the eyelid, and this is the lens. Yeah, so you can see that this is the cornea, normal cornea, having 5 layers. Outer epithelium, then Bowen's layer, and 90% of thickness of cornea is made by stroma. And after that, Descemet's membrane and endothelial complex. Anterior stroma of the cornea is compact, whereas posterior stroma is loose. So this is the normal histology of the cornea. So tissue not only provide the opportunity to confirm the diagnosis, but also contribute significant in understanding the disease process itself. The meaning to say that without normal histology, you are not able to diagnose any histopathology or any abnormal structure in the tissue or infective, whether it is infective or dystrophy. So I'm going one by one, some common infective causes of the cornea. Before that, I want to highlight that what are the stain I'm using for the corneal disease diagnosis. This first is routine examination, hematoxylin and eosine stain, then PAS stain, per iodic acid skiff, Alcian blue, Mason's trichrome, Congo red, and GMS, that is Grocott Gomory's methamine silver stain for the fungal filaments, Gram stains, and AFB stain, and calcium stain, alizarin blue or von Cosa stain. I'm using this stain mostly in my lab. So one by one, this is fungal keratitis clinical picture. You can see that there is opacity, and PK button was sent for the analysis. In this corneal button, you see that there is normal structure is totally lost, and there is perforated cornea, and there is numerous neutrophilic exudates along with prolapse of, this is the descent membrane and this is prolapsed. On higher magnification and PA sustain, you can see that there is many fungal filaments along admixed with neutrophils. So this is the PA stain where you can see that there are magenta or pink color stain, ribbon-like and filament-like structures, whereas GMS stain confirm that it is brownish black or greenish black color. So that confirms the fungal filaments, and it is a case of fungal keratitis. Now, the Pythium keratitis, which also misdiagnosed mostly as a fungal keratitis. You can see this is the clinical image. And in Pythium keratitis, this is very aggressive disease or infection. You can see in this histopathology, there is perforated cornea along with necrosis. This is the necrosed area. There is pigment dispersion, and this is one is a descent membrane, and this one is the multinucleated giant cells. On higher magnification, you can see that there is multinucleated giant cells admixed with many neutrophils and lymphocytes. If you compare with the previous image, the PA stain, the Pythium is not PAS stain positive. They are very faintly PAS positive, whereas fungus filament, they are strongly PAS positive. So in this image, you can see there is very faint hyphae-like structures. And on GMS, you can see that they are aseptate, long ribbon-like structure, and they are very faint stain. In PAS stain. On the basis of this, I diagnose Pythium keratitis. And in difficult cases, I'm doing IKI H2SO4. IKI H2SO4, where in Pythium keratitis, you see that these are the blue and green color filament-like structures. So that confirm it is a Pythium. I'm doing this in difficult situation or condition where I'm not able to diagnose on GMS. In that condition, I'm doing IKI H2SO4. Acanthamoeba keratitis, also is one infective etiology. You can see this is the opacity in the cornea, clinical image. And like that, fungal keratitis or Pythium keratitis, they also histopathologically present with the perforation. And you can see that there is tissue glue or tissue adhesive on the perforated side. And on higher magnification, you see that there are multinucleated giant cells, so they can produce granuloma formation. On further higher magnification, we can see that there is an oval structure, and this oval structure on GMS stain gives bull's eye lesion or target lesion, because it contains endocyst and ectocyst. This is the nucleus, and there is a vacuolation. So this is called target lesion or bull's eye lesion. So that confirms it is a acanthamoeba. Then microsporodial keratitis also we are getting in our lab. You can see that the clinical images. On histopathology, they are present mostly in stroma, and this is 1% AFB, and this is Gram stain. They are mostly present, looks like rice grain structure, and they contains polar band. So this rice grain-like structure is microsporidia that confirmed by 1% AFB stain, and also in Gram stain. So now this infective etiology is viral keratitis. This is the clinical image for the viral keratitis. On histopathology, you can see there is viral keratitis mostly they are very silent in nature. They produce very less inflammation, but they reoccur. So this is the case of viral keratitis. Why I'm saying it is viral keratitis? You can see in the stroma there are scattered, not high number of inflammatory cells. They are chronic inflammatory cells and plasma cells. These small round structures are lymphocytes and plasma cells. And one peculiarity is that it contains multinucleated giant cells in the area of the Descemet's membrane. So this is the Descemet membrane, which is forming a retrocorneal membrane. And in Descemet's membrane area, you can see there is multinucleated giant cells. And also we see that this epithelium changes. So this is the classical image for the viral infection. You see that this epithelium is discohesive, and the nucleus has a resin-like nucleus, and they have multilobulation. So for the unexperienced pathologist, they can diagnose it as dysplasia, but this is not dysplasia. This is the viral particle induced changes in the epithelium. So this is a case of viral keratitis. Bacterial keratitis also we are getting most commonly bacterial keratitis. This is the clinical image, and this is the PK button in GM system. You can see that the colonies of bacteria in the stroma of the cornea. So you can see that the colony is numerous colonies of bacteria in Gram's stain. So shall I continue? I have time.
Yes, please continue, Dr. Misra.
So what are the consequences of this infection? Mostly this infection can cause perforation. You can see that upper left image is perforated cornea. Then perforation can lead to the desmetocele or prolapse of the descept membrane from the site of perforation. Then there is a retrocorneal membrane formation along with the anterior synaptic formation. And this is the lens. You can see that there are two folded membrane-like structures. The upper folded, this one is the very thin, and this is descept membrane, whereas thick folded layer is, this is the lens. So lens has fibrous metaplasia, and that condition is called adherent leukoma. When the corneal surface, posterior surface of the cornea is showing anterior synaptic and posterior synaptic, then it is called adherent leukoma. So now I'm going to discuss dystrophy. Dystrophy is a bilateral condition and always family associated with the family. It is a familial condition and genetic condition. So mostly they are TGF beta I induced, mutation induced, and autosomal dominant, except macular dystrophy. So granular dystrophy is autosomal dominant inherited. So on histopathology, you can see that the corneal stroma has patch-like structures, that is amorphous eosinophilic structure. And this is the right side. This is the Mason's trichrome stain. Mason trichrome stain mainly used for the fibrosis to level the fibrosis in other tissue like connective tissue. But in corneal dystrophy, in granular dystrophy, they give brilliant red or brick red color. So this brilliant or brick red color confirm this is a corneal granular dystrophy. Now lattice corneal dystrophy. So you can see in this clinical image, there are many refractile line or lattice line or filament-like structure. And on histopathology, you can see there is amorphous eosinophilic material. They are present in between the lamella. On higher magnification, you can see on the right side, these are the eosinophilic material deposit in between the lamella of the stroma. For that, I did Congo red stain. So Congo red stain showing congophilic or orange, salmon pink or orange color stain in between the lamella of the cornea. And if you see that this is the polarizer where this refractile or apple green birefringence, also called dichroism. So this confirm it is a amyloid deposits, and amyloid deposit in cornea in like this is lattice dystrophy. And other condition where you get amyloid deposition in cornea is GDLK. This is the macular corneal dystrophy. This is autosomal recessive condition. You can see there is deposits in the cornea, and they are mostly associated with the mucopolysaccharide deposit in the corneal stroma. And all the layers of the cornea can be involved with this mucopolysaccharide deposit. For that, we do Alcian blue. This is the Alcian blue stain. You can see that in between the just below the epithelium, And in the stroma and just behind the descent membrane, there is a blue or sky blue color deposits that confirm it is a mucin or mucopolysaccharide deposits in the stroma. So that confirms it a macular corneal dystrophy. So macular corneal dystrophy are three types: type 1A, 1B, and 2. 1A means no reactivity of antigenic keratin sulfate in cornea or serum, whereas 1B reactivity intracellularly in the corneal stroma only, and type 2 is reactive deposits in cornea, both intracellular and extracellular, with low or normal serum reactivity. And overall, this dystrophy, the staining property, you can see that lattice dystrophy is congruent positive, macular is alcin blue positive, and granular dystrophy is trichrome or Mason's trichrome positivity. So other dystrophy is Fuchs. Just few words about the Fuchs dystrophy. You can see that this is the DMEC lenticule or descent membrane stripping. You see that there is gutte formation, and there is no endothelial cells. Why there is gutte formation? This is basement membrane like deposits, which is secreted by the dying or crying endothelial cells. So there is gutte formation in the descent membrane. On higher magnification, you can see that this gutte formation is embedded by the other layer of the descent membrane, which is secreted by the dying endothelial cells. So this is the severe condition of Fuchs endothelial dystrophy. Now SED is autosomal recessive condition, and it is related with the SLC4-11 mutation, and sometimes it is associated with Harboen syndrome. In this, you can see that this is the OCD finding compared with the HNE or histopathological examination finding. We can see that there is a descent membrane fragmentation and corneal edema. On further, just you see that this is the subepithelial bullae or cleft-like formation along with the basal cell hydropic degeneration, and this is subepithelial bullae. Stroma is less stained, so there is stromal edema, and you can see that descent membrane there is loss of endothelial cells. So it confirms it is a SHED or congenital hereditary endothelial dystrophy. So thanks for giving me time. Yeah.
Thank you, Dr. Dilip, for the wonderful summarization. I think it's just like the encyclopedia, but let's see.
Yeah, if not,
Dr. Aditi, your comments.
So brilliant presentation. I wish I would have, got the opportunity to have this presentation when I was a PG. So crisp and everything on point. I wish I was a PG right now. No, too good, sir. Everything.
Same
Kindly
same here.
stop sharing.
Very well explained, sir. Very well explained. Just that this question comes in the OSCE for the PGs. So, like, for every stain, they'll have 2-3 questions and they'll have to answer. You have explained it quite well.
So kindly stop sharing your slides.
Yeah.
Yes. Dr. Rasmi, from your side, if you'd like to add anything or highlight.
Yeah, no, I think I would agree that it was quite a comprehensive presentation. From the postgraduate perspective, I think he's covered all the types of infections also, including fungus, acanthamoeba. So it becomes important to remember which stain is used for which microorganism in particular. In case the other part of it is the corneal dystrophies, which also he's covered. And I think from postgraduate perspective, again, particularly the stromal dystrophies is something which they need to remember because like the Mason's trichrome was shown or how congruent staining. So these are very common questions that are asked in OSCE or sometimes put in spotters for slides. So I think that needs to be remembered from postgraduate exam perspective, and it was covered quite well.
Very true. And sometimes it is simply ask a short note or question on stains and dyes in ophthalmology,
Yes.
like that. So for
Yes.
that, I think everything has been covered. Saraf sir, before inviting you for the talk, I will like to take one brief comment from yourself.
No, I think it was a really, really extensive presentation covering pretty much everything. It becomes easier when you kind of correlate pathology with the clinical findings, and that was done very beautifully in the presentation. So I think I agree that I wish I had a presentation like this when I was a
Yeah.
postgraduate. I was just thinking that right now that this never existed when we were postgraduates.
So true.
Are
We,
all the
you, we used
PGs?
to correlate. The stromal dystrophy is a very favorite question.
Very
And that
favorite
time
question.
sitting and remembering the mnemonic.
Mugging up and we
Yeah, and the mnemonic, that Marilyn Monroe,
yeah.
that whole thing. But sir, it was so wonderful.
And best thing is that all these recordings are already available for everywhere. So if any PG or anyone who's missed the presentation or his sir's talk, he can go and watch it later on whenever it is available on the One AIS channel. So our next talk by Dr. Tosat Saraf sir, he will going to tell us few tips about ASOCTs of the cornea. Sir, kindly share your views.
Is it visible?
Yes, sir, yes. Quite visible.
Okay. So I'm going to be talking on the anterior segment OCT of the cornea. First of all, I'd like to thank Dr. Prashant and Dr. Deepak for having me over to give this insight on anterior segment OCT. So what we have to understand is that an OCT is a cross-sectional 3D image of high resolution. It uses low coherence interferometry to achieve axial resolution. And this resolution can range in microns from even up to 1 micron to about 20 microns. So this was first demonstrated in 1994, and later on we used longer wavelengths, which had better penetration through the sclera. The basic principle is it's a Michelson's interferometer. A reference beam of infrared rays is used to measure the time delay and intensity of infrared rays reflected from various tissue layers of the eye. These reflected rays then collectively form an interference pattern, and then multiple patterns of these interference patterns create a cross-sectional image of the particular tissue of interest. So this can be either in the cornea or in the angle or in the retina, whichever tissue you are imaging. Now, basically, ASOCT is classified as time domain and Fourier or spectral domain OCTs. So what we have to basically understand is that in Fourier domain, it's a shorter wavelength of light that's used, so the penetration is not as good. The scan width is 3 to 6 millimeters, and the resolution is about 4 to 7 microns. So it's a higher resolution, but the penetration is not as deep. Whereas in time domain, these have deeper penetration, they have a longer wavelength of light used, wider areas of capture in a single image, and the resolution is about 15 to 20 microns. And these are the various different imaging modalities from various different companies. You can see the Visante and Heidelberg are time domain OCTs, and the Spectralis and RTView from OptoView, these are the Fourier domain OCTs. Swept source is a kind of Fourier domain OCT. It uses a rapidly tunable laser as the emitting source of light, and it produces high resolution images of 10 micron axial resolution and 30 microns transverse resolution. It has a high speed of scanning, and it can visualize 360 degrees of the anterior chamber angle in 2.4 seconds. So it gives a very good global picture of not only the cornea, but say the white to white. And I'll come to examples of all this, as well as the anterior chamber angle to look at things like glaucoma or narrow angles in glaucoma as well. So how does OCT and UBM differ? This is important for the postgraduates. The very key important point in this is to understand that OCT, for the anterior segment at least, it images anterior to the iris. So you will see everything in the iris. You'll see the angles. You'll see the cornea. You'll see the corneoscleral junction, but you will not see behind the iris. So you will not see the sulcus, for example. For imaging the sulcus, it is the ultrasound biomicroscopy, the probe, that the UBM that has to be used. And the difference is it's a slightly more contact-based procedure. It requires an immersion bath for the UBM. So coming to the different types of lesions that I'm going to basically classify in ASOCT imaging, we'll go stepwise with first conjunctival lesions. So we can look at ocular surface tumors and various other conjunctival lesions. So this is a pterygium, which you can see the clinical photograph on the left side. What you can see on the right is the ASOCT of the same thing. And if you can see my cursor that's pointing over here, it shows a normal epithelium because the pterygium tissue is at a subepithelial level. There's varying levels of hyperreflectivity, as you can see here. And there's a dense hyperreflective fibrillary subepithelial lesion. So if you have to mention this or describe it as a spotter, this is what you see typically in a pterygium. In an ocular surface squamous neoplasia, what you can see here, there are some feeder vessels, there's some keratin on the surface. And when you look at the ASOCT features in this, you'll see that the epithelium is thickened. There's a hyper-reflective epithelial layer, as you can see here. You look at this area that it's much more intensely white compared to the rest of the cornea. And there's an abrupt transition from the normal to the abnormal epithelium, which you can see over here, where that green line tapers off into the white area. So this ASOCT, the advantage in OSSN is that it can be used to detect subclinical disease where you're not having very much, where your clinical findings are not helping you to a very large extent. And it serves as a powerful tool because it's a non-invasive diagnosis of the OSSN. It helps to guide treatment initiation and, of course, for monitoring the disease. Once you've started the patient on, say, mitomycin or interferon, then, or for example, if you do a surgical excision of the OSSN and then you want to monitor the progression or the recurrence rate, that is where ASOCT has a big role in these lesions. Coming to the cornea, one very important fact that you can see is you can denote the level of scarring. So if again you see here, there's a hyper-reflective band over here suggesting the corneal scar, which is seen nicely on the slit lamp image as a coin-shaped lesion on the upper temporal side. So what you can see also, if you look at this arrow over here, it tells you the direction in which the OCT scan is taken because it takes a 360 view of the same thing. Now, it's important in corneal scars because it tells you the depth. Now, very often on slit lamp, we manage to get a gross assessment of the depth, but the actual depth helps to guide the treatment that you would do. So if it's a very superficial scar in the center, a PTK would be a good option for that, where you use a laser to remove the scar. If it's at a deeper level, say it's about 200 microns deep, you can do a anterior lamellar keratoplasty, something like a femtosecond assisted, where you would have a laser anterior lamellar keratoplasty, or you can do it with a microkeratome blade, which is used for LASIK with the free cap setting. You can do that, and that would take care of superficial scars up to about 200-250 microns deep. If you go deeper than that, then you may have to look at surgeries such as DALK or deep anterior lamellar keratoplasties. Now, what you can see in this image here, these notations that you're seeing, that is actually a caliper. It's a tool that helps you to determine what exact depth there is to the lesion, and of course, to determine the corneal thickness at any particular point. So you can drop the caliper from all the way out on the outer side of the epithelium down to the Descemet's endothelium complex to see actually what is the thickness of the cornea, and you can drop a second caliper to see what is the depth of the lesion. As you can see here, this is at about 69 microns. Now, this is another example of a denser corneal scar. This would be a nebulomacular scar. What you can see here is that the scar, the hyperreflectivity is extending throughout the layers of the cornea from the anterior, just below the epithelium, right down to the Descemet's membrane, and it's a central corneal scar. Now, this kind of patient would obviously not respond well to a PTK or any kind of superficial treatment. You would probably have to do a penetrating keratoplasty or at least a deep anterior lamellar keratoplasty to treat this. One important point to realize in anterior segment OCT with corneal scars is that most of the time scarring is associated with thinning of the cornea and flattening of the cornea as well. And that is how you would differentiate it from, say, corneal edema. You may be confused by the clinical picture, but generally corneal edema, the cornea would be thicker. It will not be flatter as it would be in a scar. So typically in scarring, you get a hyperreflective lesion in the corneal stroma associated with flattening or thinning of extensive scarring. If you have a very dense scar, you get what is called backshadowing. So if you see a very, very dense scar, you may not get an image, especially in the older OCTs, you would not be able to see anything beyond that scar. And the OCT helps to measure the depth of the lesion and to guide treatment, as I mentioned. Now, coming to corneal ectatic disorders, this is a patient of keratoconus. What you can see on the slit is a slit image on the slit lamp is that there's a thinning and a bulging of the cornea forward. As the name suggests, it's a conical cornea or a keratoconus. Now, typically in this, you would see, as you can see here, that the thickness of the cornea in the thinnest location is about 300 microns, 307 microns. That's showing a thinning of the cornea. You can also see a bending forward of the posterior layers, which shows that there is elevation compared to a reference surface that is a hallmark of keratoconus. And these kind of ectatic conditions, then we have to see how to go about treating them. If the cornea is above 400 microns in thickness, we can look at things like C3R to cross-link the cornea. If it's a very advanced disease, then for controlling the disease process, you would probably look at, again, a keratoplasty, like a deep anterior lamellar keratoplasty in these patients. For visual rehabilitation, of course, contact lenses and glasses play an important role in keratoconus. But this is typically what you see on the OCT. You see a thinning of the cornea as well as a bulging forward of the cornea. Very important to remember that in keratoconus, we'll come to pellucid marginal degeneration later, but in keratoconus, the thinnest and the steepest point generally correspond. That means it's the same area which has the thinnest area of the cornea and the area of maximum elevation on the front and the back of the cornea. Whereas in pellucid marginal degeneration, those points don't correspond, and that is the difference between the two. So the epithelium, what we have to remember is in keratoconus is thinned out over the protruding stroma and displays an annular thickening around the surrounding flatter stroma. It basically gives a donut configuration. There's increased epithelial thickness and stromal thinning at the corneal apex and a hyper-reflective Bowman's layer, or you may get Bowman's breaks. You may see breaks in the Bowman's layer. These are risk factors for suggesting that hydrops can occur. The other place where ASOCT is important is the post-C3R demarcation line. You can see this line at the deeper levels of the stroma. C3R is collagen cross-linking. It's done with riboflavin eye drops. You remove the corneal epithelium and you use ultraviolet light to create links in the cornea. You're cross-linking it to stiffen the cornea because in keratoconus, the cornea is very elastic. It tends to bulge forward more. So this demarcation line is actually gives you a suggestion whether the cross-linking procedure that you've done, whether there's actually it's working. It's a layer of dead keratocytes at the level where the cross-linking effect has taken place in the stroma. So this is useful in various studies to see whether how deep the cross-linking has actually worked, because as was mentioned in the previous talk, the deeper layers of the stroma are less strong, so you're trying to stiffen them to give increased strength to the cornea. Now, hydrops also occurs in keratoconus. What you can see here is this fluid, this hyporeflective area and the Descemet's behind it. It's a break in the Descemet's membrane through which fluid has actually gone into the corneal stroma, and you're getting these vacuolated areas within that. So that is acute hydrops. The patient generally presents with blurry vision from a long time, but with a sudden drop in vision. And these patients, what happens is that there's sudden corneal edema. You may be confused as to what is the cause of the corneal edema, but the ASOCT helps to guide this because you can very clearly see that there are loculations in the corneal stroma as well as a break in the Descemet's membrane through which the aqueous has permeated into the corneal stroma. The second image on the right shows that this has been treated with a gas bubble. So you can use either C3F8 gas up to 14% or SF6 up to 20% to kind of tamponade this. And you can see then that there is a resolution of that corneal edema. The image on the left shows definitely that the corneal thickness is increased, but then when you put the air bubble, the Descemet's membrane has been pushed up and therefore the corneal edema over a period of time tends to respond well to this. If you have conditions where the gas bubbling itself alone will not help, you can also put what are called compression sutures. So what is hydrops? It's a break in the Descemet's membrane followed by leakage of the aqueous humor into the stroma. And the ASOCT helps in assessing the location, size, and morphology of the break and its evolution with time. Also, it helps to guide whether decimetopexy, which is the use of air or gas, whether it's helping to resolve the edema. If it's not helping, if compression sutures are not helping, then over a period of time, again, the patient would have to undergo keratoplasty. Now, this is an image of, again, an ASOCT. What you can see here is these two hyporeflective channels. These are called Intacs rings or intracorneal ring segments. You have two types. You have the Kera rings and the Intacs rings. Basically, these are placed about three-fourths of the way down in the mid-peripheral cornea. And the reason why these are placed are to create a tensile effect on the periphery of the cornea to flatten the center of the cornea. So you're trying to flatten the conical area, which is central or just paracentral, by placing these beyond that. This is a very effective treatment option, especially in cases where post LASIK you have developed an ectasia or a bulging forward of the cornea. So this is basically one of the treatment modalities for improving the vision in keratoconus patients. What you can also see in this ASOCT image is this hyper reflective line on top. That is actually a bandage contact lens above the level of the epithelium that you can see over here. Now coming to another ectatic condition, that is pellucid marginal corneal degeneration. What you can see here that this is where ASOCT scores over a device like the Pentacam or a Scheimpflug imaging, because it gives you a much more larger area of view. Although in the Pentacam on the Scheimpflug image itself, you can also go and see this particular thing, but this gives you a much larger view. What you can see here, like I mentioned earlier, is that the thinnest location is actually inferior to the steepest location in the cornea. And that is how you differentiate this from keratoconus, along with the topography image of a crab claw appearance. Now coming to other things like corneal transplantation, what you can see here, this is an image of a post-DSEK eye. This is an endothelial transplant where we've taken some amount of the patient's, the donor's corneal stroma and the endothelium complex. This is used to treat patients who have, say, pseudophakic bullous keratopathy after a cataract surgery, or who have Fuchs endothelial dystrophy along with cataract when you perform a triple procedure and you do a cataract plus a corneal endothelial corneal transplant. So DSEK is one of the procedures along with DMEK, which is Descemet's membrane endothelial keratoplasty, which can be then monitored very well with a anterior segment OCT. So I'll show you an example also later where the DSEK graph is not attached well. Now, deep anterior lamellar keratoplasty, like I mentioned, for keratoconus or for deep stromal corneal disorders can be done. And you can see very nicely here the patient's own Descemet's membrane. And this is actually the cornea, the donor cornea that has been attached to the host cornea at this particular area, and it's covered by a bandage contact lens. So like I mentioned, where does OCT help in corneal transplants? It is to look for scarring and fibrosis and to decide between a penetrating keratoplasty or an endothelial keratoplasty. If you have a large amount of scarring in the anterior layers of the cornea or in the corneal stroma, you would not prefer an endothelial keratoplasty. Whereas if you have edema, then an endothelial keratoplasty will work. Intraoperative OCT has also been used to help in maneuvering the graft, assessing whether there's fluid in the interface which will prevent the graft from sticking. Venting incisions can be placed more accurately to drain that fluid. And post-operatively, it's very important to localize a graft detachment, to look at the fluid monitoring in the interface. If a graft has been placed upside down, you can monitor that. Interface keratitis or ingrowths can be monitored, and monitoring of the host and graft thickness. So this is an example of a patient where you can see that there's this cleft between the host cornea and the donor cornea. This is a DSEC lenticule, what you can see is that this is actually detached from this particular area. And this lenticule is becoming thicker over a period of time because it's not attached to the host cornea. It's not, the endothelium is not functioning. Now, in this kind of patient, you would think of rebubbling. You'll put an air bubble again to attach this DSEC lenticule to ensure that it basically is accepted in the body and the graft works well. So this is again an example of keratoconus where we've done a deep anterior lamellar keratoplasty. For that, you can see the difference in the thinned out hyperreflective area just below the Bowman's membrane in the keratoconus eye, and followed by that the DALK was done, and this is looking a lot better. In DALK specifically, it helps to assess corneal thickness, level of scarring, if any, and helps to decide if a pneumatic dissection is possible. If you have extensive scarring, then you may have to go layer by layer to dissect in a DALK. Intraoperatively, it ensures that the depth of trephination is proper, because in DALK you want to preserve the Descemet's membrane and trephine just above that. Ensures that the air cannula has reached adequate depth, and it gives you a very nice kind of intraoperative view of whether the bubble is formed in the right layer in a big bubble technique. It can help pick up micro perforations intraop that can be managed to ensure that the DALK can be completed. And in DALK, you can have a pseudo anterior chamber. You have double. You may sometimes leave the host Descemet's membrane along with the other Descemet's membrane, and you'll have a double anterior chamber formation. Coming to corneal dystrophies, this is a clinical photo of a granular dystrophy. What you can see again are these hyper-reflective excrescences. You can see this in various different dystrophies. If you have Bowman's membrane dystrophies like Thiel-Behnke or Reese-Buckler dystrophy, again, you'll get these hyper-reflective lesions. You can monitor lattice dystrophy as well on the ASOCT. Coming to cataract surgery, yeah, the very important use of this is in Descemet's membrane detachment. That's one of the most important uses. If you have a corneal edema that's not resolving over a period of time after cataract surgery, it's always important to think that this could be a Descemet's membrane detachment, as is seen in this image, where you can see a fairly large area of DMD. Now, ASOCT has also helped to classify the Descemet's membrane detachment into taut, straight line kind of Descemet's detachments, where there's a separation of the pre-Descemet's layer, the Duas layer, together with the Descemet's membrane. The type 2, the DMD, is undulating and is made of two parallel hyperreflective lines separated by a narrow dark space. So this is the characteristic appearance that can be seen in the second image. And the mixed type is, you can see here that there is a taut band followed by these undulations as well. So these are all important because they guide your treatment again for Descemet's membrane detachment after a cataract surgery. Now, this paper was also published, which looked at ASOCT-based management protocol. It's called the HELP protocol. Basically, you have these three zones of the cornea, which you can see the Z1, Z2, and Z3. The Z1 is in the central 5 millimeters, Z2 in 5 to 8, and Z3 is the peripheral 8 millimeters. Anything involving zone 1 and 2 with a height greater than 300 microns and a length greater than 2 millimeters, you require surgical intervention. If the height is between 300 to 100 microns and the length is 1 to 2, you look at which zone it's involving. If it's central, if it's in zone 1 and the pupil is involved or not involved, you'll do surgical management. If it's in zone 2 or 3, you can use medical management like hypertonic saline drops and steroids and watch for about 4 weeks. If it doesn't resolve, then you go in with surgical management. If it's a very small DMD, less than 100 microns in height, less than 1 millimeter in length, you can observe it initially with medical management and see for resolution. So this is a typical PBK, pseudophakic bullous keratopathy. You get these epithelial bullae in the epithelial and subepithelial layer. You see these hyporeflective cyst-like lesions. Along with that, you get waviness at the Descemet's endothelial complex. And of course, if you drop the caliper, you can see that it's a 865 micron cornea. And what is characteristic of this is you can see that there's no scarring. There's very little hyper-reflectivity in the cornea. That tells you that this is a PBK, and this would do better with an endothelial keratoplasty, and you may not need to go in for a full thickness keratoplasty in this case. In refractive surgery, then we come into one other place where ASOCT helps a lot is to look at ICL sizing. ICLs are implantable Collamer lenses, and we want to get an ideal vault height. What you can see here, these two hyperreflective lines are the ICL, and this hyperreflective line below is the anterior surface of the crystalline lens. So the vault that we want ideally post ICL is 200 to about 800 microns. You would want it ideally to be about 500. You can see here that this particular patient, it's achieved about 600 microns of vault. The reason why vault is important in ICL is it tells us whether you're going to have complications. Like a high vault would cause angle closure glaucoma, whereas a low vault could lead to cataract formation. So it's very important for ICL sizing to actually look at the ASOCT, to look at the vault that you've got post-operatively. If you have a very low or a very high vault, you may have to go in, do another surgery, take out the ICL and replace it with a different sized ICL. This is an example of a high vault. You can see here that it's over 1,000 microns in vault, and therefore you would have to closely monitor this patient. You can already see that the angles are becoming narrower on this side, and this patient would be predisposed to angle closure glaucoma. In LASIK itself, the ASOCT also plays a role because you can see the depth of the flap. You can see here this hyperreflective line. That's a cut where the flap has been created. Normally, it will be about 100, 110 microns these days, but older flaps used to be thicker. It's important because if you're doing a retreatment, if post LASIK a patient has developed a refractive error, you may have to lift the flap and you may need to see how much residual stroma is left for you to ablate. Or if you're doing a surface ablation or a PRK to treat, then again, you want to see what depth the flap is at so that you don't go through it. Another place where it's very useful in LASIK is you have what is called epithelial ingrowth, especially if you have retreatments where you lift the flap again, the epithelium grows into the interface between the flap and the stroma, and you can again see these hyper-reflective lesions here, which are suggestive of an epithelial ingrowth. If an epithelial ingrowth is in the periphery of the cornea, you can treat it either with YAG laser or you can just observe it initially. If it tends to come towards the center of the cornea and it's causing a necrosis or a thinning of the flap overlying, then you may have to lift the flap, clean the epithelial ingrowth. If the flap is getting very necrosed, then you may have to sacrifice the flap as well. So that's where it's important in LASIK. Another area where it helps in LASIK is pressure-induced stromal keratitis, where you get a hyporeflective pocket in the corneal stroma, which tells us that there's high pressure because these patients are generally myopes, and with steroids, they do get high pressure. So with that, I would like to end my presentation. Thank you so much. And I would be free to take any questions if there are.
Thank you, Dr. Saraf, for not only explaining everything, but you also cover the treatment and the recent advances part of each and every topic. Dr. Rasmi, anything you would like to add or say?
Yes, I think Rushad has covered it pretty comprehensively, going from to indication and going from anterior to posterior, including grafts, dystrophies, as well as the refractive applications. And particularly for the postgraduate, again, from postgraduate perspective, it becomes important the points that he said about how to differentiate between scar and corneal edema. What are the different layers of the cornea and how you're supposed to identify them, which of them will be hyperreflective, how the fluid pockets are hyporeflective. And some of the important spotters or OSCEs that are usually shown include corneal scars. They do include LASIK flaps. One of the common mistakes made at postgraduate level are, which I've particularly seen, is that there is always a confusion between where the LASIK flap is versus where the Bowman's layer is. So I think it becomes important to kind of show that the first hyperreflective layer is the tear film and the epithelium complex. Then the next hyperreflective is the Bowman's layer, and the LASIK flap is usually beneath that because the thickness of the LASIK flap is usually going to be more than 100 microns. Whereas the Bowman's layer is going to be in the initial 50 microns, just beneath the epithelium. So that becomes like a problem in the viva a lot of times. We've seen that. and including DM detachment as well, which is shown beautifully, and the ICL OCT. So these are some of the common OCT images which are shown in DNB exams as well as in MS exams in the OSCE. So if people have heard that part very well, then he's explained it beautifully.
Thank you. Dr. Aditi.
No, sir, completely agree with Dr. Rashmi. Mainly the OSCE part, the PGs need to know how to differentiate the scars with the dystrophies and with the Lissig flaps and different diagrams they need to differentiate. So I agree with her.
Excellent presentation by Rishad as always. So rightly, Rashmi has already pointed out the point. There was one case I remember where it was a photo of a perforated corneal ulcer stated post cyanoacrylate glue and BCL, where the kid got confused between, the BCL, whether it is a tear film, what is it, or the scar. So it's always good because you are given a clinical picture, a short history, and then you can, collaborate with it, and then you can answer. Take your time and then answer. Just don't jump to the point that the first year is going to be this. Just see the photo as well of the clinical picture or ask some few pointers and then go ahead. So this is one of the points that I had seen in one of the students committing this mistake. And DMD is a very favorite topic. And once you're given the photograph, then you have to give the answer, which Rishad has already explained, the classifications and what are the treatment options. So I think perfectly he's included everything.
So the glue will, yeah, it's a very hyper reflective thing. You'll
Yeah.
basically not see anything behind a layer of
Right.
glue on the.
Right. So that the BCL is somewhat. So they give a clinical photo and the ASOCT photo.
I think if I can add something here. So one of the pointers how students can appreciate where the BCL is that versus the tear film, is that tear film is just above the epithelium, but BCL usually has some thickness. So BCL is usually 90 to 100 microns thick. So you're going to have that much of a gap above the epithelium and then see a hyperreflective line. So if you're seeing that, that means it's the BCL. If the hyperreflective line is just above the epithelium, it's usually the tear film epithelium complex. So that can give a clue of how much distance there is of the first hyperreflective layer.
Philip, sir.
Yeah. Tell me, sir. Any questions?
Sir, no question. Just if you like to add anything or.
Yeah, for histopathological point of view, tissue glue that is not stained with hematoxylin or any stain. It just look like refractile bodies. What I have shown in my one of the picture on histopathological examination. So tissue glue, they are not stained by any stain.
I think both talks are so extensive that there is nothing left to discuss or we can add on. But still, we thanks both our speaker, Dr. Saraf and Dr. Dilip, from the core of our heart and whole EIS ARC team. All the three discussant and expert panels today, Dr. Aditi, Dr. Rasmi, and Dr. Kustum, for giving us your valuable time and guiding the young minds. One of the best thing is both of you touched the topic which is not very common. Means not very common means the literature or the things are not available so much as for other things. And if I remember our residency days, we usually keep on searching and somewhere we got one photograph or two photograph on it, but not like such a extensive talk or the encyclopedia which we learned today. With these words, thank you everyone. Thank you for helping EIS ARC in teaching the young minds.
Thank you so much.
Thank you. Thank you, sir.
Thank you.
Thank you all.
Thank you. Bye.